Professor Miguel León-Sanz, working at University Hospital 12 de Octubre, affiliated to the Medical School of Complutense University, Madrid, Spain. And for the next few minutes, I'm going to talk to you about clinical dyslipidemia. Lipid metabolism is very complex, with different genes, proteins, receptors, and hormones involved in its regulation and susceptible to be with alterations that lead to atherosclerosis. Atherosclerosis is a systemic disease that could be developed in different vascular beds, like the coronary disease, or strokes, or intermittent claudication. And physicians taking care of patients with atherosclerosis need to keep this broad approach to the patient. It is important to identify patients at risk with the different risk assessment tools that are available, for example, the Framingham Risk Score or the European Score Chart. Once the patient is identified, we should institute lifestyle intervention measures. And if this is not enough to correct the underlying problem, we can use different drugs. Statins are very effective, but still 60% of patients treated with statins are still at risk of developing cardiovascular disease. Fortunately, we have new molecular targets for the treatment of dyslipidemia, and today we can mention, for example, proprotein convertase subtilisin kexin 9 antibodies directed to increase the number of LDL receptors in the membrane cell. We can also use antisense oligonucleotides that decrease the synthesis of ApoB protein, or inhibitors of microsomal triglyceride transport protein that decrease the assembly and synthesis of ApoB-containing lipoproteins. We can also use, probably in the future, drugs that inhibit CETP or cholesterol ester transport protein. We hope that the availability or better drugs to approach this metabolic disorder will be accompanied with a decrease of major cardiovascular events, and we will make sure that patients can progress in the treatment of this very common metabolic disorder.